So I'm doing the pro for endovascular therapy and stroke. This is a meta-analysis that's published in the European Heart Journal in 2015. The clinical question is, does thrombolysis plus endovascular therapy, what we'll call EVT from now on, improve outcomes compared to thrombolysis alone? You can thank ACEP and a number of other large national bodies for making the standard of care in stroke IV thrombolysis. Up until last year, that was a grade A recommendation in spite of there essentially being one good study out of 12 for IV thrombolysis, systemic thrombolysis, and stroke. So it's the standard of care. It's now a level B recommendation from ACEP, but all the European and American societies pretty much got on board pretty quickly in recent years. So that would be the standard. Yeah, and the reference to the European Heart Journal. Population, there's 2,423 patients from 8 RCTs presenting with what's presumed to be a large vessel anterior circulation stroke, further shown by CT. Intervention, that would be EVT, which is in these studies either clot retrieval or catheter-directed thrombolysis plus systemic thrombolysis. And the comparison would be systemic thrombolysis alone. Really, the comparison's kind of best maximal medical therapy because there are some folks that had contraindications to thrombolysis that were still included in the study. Outcome is MRS 0 to 2 at 90 days. That's a modified Recon scale. That's an ordinal analysis of disability after a stroke. 0 being no disability. I think 5 is death. Odds ratio was 1.73. 95% confidence interval was 1.18 to 2.53. The number needed to treat was 9.3 for all 8 of these RCTs, favoring the intervention, which is EVT. The all-cause mortality was actually a little bit lower in the EVT arm, although that didn't reach statistical significance. Rate of intracranial hemorrhage was not higher with EVT. The odds ratio was 1.07 with a 95% confidence interval of 0.73 to 1.56, crosses 1, not statistically significant. Analysis from the recent trials, from the 5 published in 2015, showed further benefit. Odds ratio of MRS 0 to 2 was 2.42, 95% confidence interval 1.91 to 3.03. A number needed to treat of 5 with similar safety results to all 8 RCTs. The author's conclusion in the paper: in centers with advanced systems of stroke care, EVT significantly improved functional outcomes without compromising safety. In patients with acute ischemic stroke due to anterior circulation, large artery occlusion, compared to standard therapy. So I'm about to go through real quick just the best evidence in emergency medicine checklist. It's an evidence medicine-based approach to analyzing anything from meta-analysis, RCTs, whatever. They kind of have their own form they do. Diagnostic question is clinically relevant with established criterion standard. Yes. Systemic IV TPA is current standard. Again, it's endorsed worldwide. MRS is widely used to analyze efficacy of intervention, stroke, all-cause mortality, and intracranial hemorrhage are used as measures of harm. The search for the studies was detailed and exhaustive, yes. It was a pretty thorough look. They looked, English language only was really the only restriction that they used when looking through all the papers out there. Methodological quality of primary studies was assessed for common forms of diagnostic research bias. Yes. Assessment of studies are reproducible. Yes. Low heterogeneity for estimates of sensitivity and specificity. This is a little bit variable. We'll talk about it more here in a second. The summary diagnostic accuracy is sufficiently precise to improve upon existing clinical decision making. Yes, I think it does improve on what we should do clinically now. Key results. Pooled analysis, authors found a shift towards improved functional outcomes in 90 days in patients randomized to receive EVT compared to standard therapy. It significantly improved functional independence rates. MRS 0 to 2 is basically the ability for you to be independent versus not. And so, again, you're talking an absolute risk reduction of like 13%, like 43% versus 31% or 12%. Odds ratio 1.73. P is 0.005. Number needed to treat is 9.3. When you look at it for lower mortality, it was 16.2 versus 17.3%. Again, not statistically significant, but you have a tendency towards lower mortality with EVT. The rate of bad outcomes, mortality, bleed, essentially the same, 5.1 versus 4.8% for bleeds, for instance. So overwhelmingly positive. That's the conclusions that the authors make.
So it's fairly obvious that some great minds went through some amazing mathematical hurdles to come up with some very convincing numbers. But if you give me a moment, I'm going to advocate that we should not be looking at this paper as a new standard of care, and I may even argue that it should not have been done. So the first thing is, even though TPA is now our accepted standard of care, I don't think that means that we should forget that it is still controversial. The data that supported TPA becoming the standard of care, we can't just wipe that away and pretend like it is our cure-all. Second, all of these studies were performed in multi-specialty centers where they were using the latest and greatest technology with the backing of the people developing the technology, and they're also the people that are performing the highest numbers. So they have the best proficiency and the best chance of success with these procedures. Third, the patient populations for these RCTs that were included in this meta-analysis were very selected. They were looking for patients that were having the best likelihood of success with this procedure. 4 out of the newest trials that were included in this RCT, 4 out of 8 of them, actually 5 out of 8 of them, were stopped early, 1 due to futility, and 4 because they thought that they had good enough results, they did not need to complete their trial as was originally planned. And last, I think the nail in the coffin is addressing the heterogeneity of these studies. The I2 score, which Jason was introducing you to, was greater than 50%, which means that there's greater than 50% of the patients in this meta-analysis had differences not due to chance. So, in summary, I think we have to be very careful when they conclude in this meta-analysis that we can use these numbers as a new standard of care, and that we should be pushing to look at time as brain, and that we need to be trying to do endovascular code strokes with people. There's a lot of reasons to be cautious against that.
Heterogeneity. Last 5 trials, I-squared was 0%. Is it really 0%? Probably not. But it's also probably not 100% when they're reporting a heterogeneity as 0%. So the 5 most recent, keep that in mind, 0% heterogeneity from what they're actually looking at. Tpa controversial. It is. Again, that ship's kind of sailed. It's not really what we're addressing here. Like, it is controversial. That's what we're doing. All the national bodies are pretty much on board with the same. It's essentially the standard of care, irregardless of your disagreements with TPA. If anything, think of it as the Plavix of stroke care. Neurocenters, great. Transfer your patient to a neurocenter. Nobody's arguing that this should be in a critical access hospital, that you should have a neurointerventionalist within 20 minutes of the place to come in and take care of these stroke patients. In a second, I'm going to run through the numbers real quick for you, but nobody's arguing that this needs to be out in every single community setting. There's some that would argue that you should put this in big academic centers, referral centers like us, Atlanta, maybe Columbia, Wake, Duke, places like that where you can have transfers to the area for the stroke care. Remember that the trials looked as far out as 12 hours for EVT with no change in outcomes. Same great outcomes, no difference in the negative outcomes, out to 12 hours. We need to be very selective. That's what we're looking at here. They didn't look at posterior circulation strokes. Anterior circulation strokes, get your ACAs, which are very small, the anterior cerebral arteries, which are like 2% of strokes, but then get the MCAs as well. That's 2/3 of your strokes are MCA infarcts. You're talking about proximal M1 segment MCA infarcts in these studies, and you're talking about basically like distal internal carotid infarcts. These are massive, massive strokes with horrible outcomes. Understandably selective, you should be. Stopped early. The absolute risk reduction is 20%. Number needed to treat is 5 from the trials from 2015. I mean, it's arguable that for the millions of dollars that are spent on these trials, it's okay when you have that much of a benefit to stop early. They're really expensive to run multi-center RCTs, obviously. It was overwhelmingly positive. Stroke's a big controversy. Other things, there wouldn't have been quite so much controversy with stopping early. And then, so real quick, my bottom line, between 650,000 and 700,000 ischemic strokes in the U.S. annually. Approximately 2/3 of these strokes are anterior circulation, MCA primarily, which accounts for as many as 450,000 strokes in this country. Dr. Jeff Saver, which was the PI of the SWIFT Prime trial, estimates 60,000 of these strokes would be eligible for EVT based on most recent guidelines. So that's with perfusion imaging. It's basically showing that you still have some kind of collateral, you still have some kind of perfusion around your stroke. Theoretically, you eliminate the ischemic insult, that infarct, the remaining damage is going to be small. So 60,000 eligible for EVT in the country. With a number needed to treat a 5, that means an additional 12,000 patients a year would have a favorable outcome as a result of EVT. Does that make sense? To put this in perspective, the number needed to treat for PCI and STEMI is 35 to prevent mortality at 1 year, approximately 15 to prevent one reinfarction. That's roughly 300,000 STEMI patients in the U.S. annually. That's an additional 8,571 lives saved, possibly 20,000 reinfarctions prevented. We're all on board with PCI and STEMI. Arguably, it's just as big of a benefit for EVT and stroke. Just consider that. And again, you're not talking about this being everywhere. You're talking about a handful of patients each month at a major referral center in the U.S. The biggest argument that I think can really be made is whether we marshal the resources to do even that. Neurointerventionists, a new cath lab team of sorts. Obviously, that kind of stuff is expensive. It's an expensive resource to have. But again, we've all jumped on board with it for PCI and STEMI. Arguably, the benefit is potentially greater even here. It seems like something that we should get behind.
So first, I feel like I have to point out that cost does matter. When I was at the Masters just recently working with some of our EMT directors at some of the more rural areas, they talk about how we fly people for traumas all the time, not realizing that that flight often bankrupts that family. Transferring them still has a cost. All of these procedures, the device, using the doctors, the neurointensivist time, that still has a cost, and that does matter, even though we are going to center them all at multi-center trials where they will get this level of care. First, even within this meta-analysis, they try to make the argument that only half of their meta-analysis matters. Why? Because the first 3 trials showed no benefit, so they try to cut out half of those, saying that those are the only ones that they need. And it's true, those last 4, or the 2015 trials, have a heterogeneity of 0, but also consider that 4 out of the 5 of those were stopped early. And when Jason mentions that, of course they stopped it early because it's expensive, when they were planning the trial, they planned it with a certain number of patients needed to actually prove their concept. If you flip a coin, heads or tails, the first 5 times you get heads, that doesn't mean you stop. So the heterogeneity, they put in one line in this meta-analysis that their I-squared score was greater than 50%, and then they spend a whole paragraph talking about their sensitivity analysis removing a single trial. If you pour a bunch of different colors into a pot and it turns black, and you pull one out and the pot is black, you still have to look at your I-squared score. Comparing these trials together, your heterogeneity is still unacceptable.
All right, guys, so well presented. Let you each state why today, if you saw a stroke that would have been eligible for these studies, would you really be pushing for them to go and have this therapy done? Or do you think that they don't really benefit?
Me personally, if it's somebody that has a relatively reasonable quality of life, like think of a 55-year-old guy with a dense proximal MCA stroke that was otherwise, completely normal before, CT initially can be done. CT head non-con initially can be done almost anywhere. You're examining the patient and see what's presenting as a large, dense MCA infarct. Yeah, absolutely. I would transfer that guy to a stroke center that could, potentially do further imaging. The CTA that's probably needed. I guess if they can do an MRI that quickly, MRA, they're willing to use that as, with contrast, as a measure of a small ischemic nidus there and actually do an intervention. Like, I would want that for myself. Most of y'all don't know this. The reason I got into medicine to begin with is not because I was interested in it. My dad at 55 had a large dense left MCA or right MCA stroke that left him disabled, unable to work. I would have wanted that for him if he was able to get it at the time as well. It is positive. It is overwhelmingly positive. Even the most skeptical folks in the U.S. have some reservations about the studies, but are in favor of pursuing this further.
I think it's inappropriate to look at this meta-analysis and use it as justification to start transferring people to get this therapy. I think that the degree to which they had to restrict the patients they were able to select to do the therapy means that the odds that the patients that we see in the community transferring for this therapy because we think they're having a bad stroke means that it's going to have such an indication creep that they're not going to get the same results. It's going to be more like the first 4 trials we saw with this, where they got no benefit or they had harm.
All right, guys. So let's give them both a hand for doing very well. So, round of applause before we actually ask people how they truly feel, because these were assigned. If you think that Jason has convincingly shown that this paper suggests that this should be used today to change management, let's hear a round of applause. And if you think that we have enough evidence that this is not ready for prime time, and that the indication creep and transfer problems and the costs are too much, let's hear a round of applause. All right, so very well done. I think, Jason, you take it, but very well fought on both sides. Do you want to let us know what you actually believe?
I was really impressed. I feel like the 2015 trials, that they did all stop early because they had great benefit. I think it's because they were more selective in the people that they were treating. So I think if we were more selective in general with the people we treat, we'd see more benefit.
Okay. And
but
Jason?
yes, I would transfer to
so
a
you would
stroke
transfer
center.
right now if you were moonlighting in a small
I
hospital?
think you have to.
Okay. And Jason, what do you think?
Yeah, I'm skeptical. I mean, most of you guys know I'm a bit of a nihilist when it comes to medicine and medical therapies. Like, nothing is ever as good as you think it really is. Like, we already see an indication creep at our own hospital for EVT. So I think the data is pretty darn positive, really. 5 RCTs in a year, that's a lot. We all jumped off the EGT train, for essentially less. But, I remain somewhat skeptical. I think it'll still have to be studied further. I do think that the selectivity is a good thing. It should be a narrow indication. It should be somebody that has something shown. They're using something called an aspect score, ASPECTS, all caps. They're actually trying to score, the neuroradiologists are trying to score the ability to kind of reperfuse in the area of the stroke and stuff like that. I mean, I think those are all good things. I think the cost of a CTA, an evaluation with an aspect score for eligibility is a good thing, and something that you want to have. And folks like this, not everybody should go for EVT. I'm not trying to argue that. I agree with Jen that cost is a tremendous issue and a tremendous burden on the U.S. economy, and something that's going to have to be addressed in our generation.